Hospital at Renaissance. We're just going to do a little bit of house rules. You have your phones, put them on vibrate. We've got men's room and ladies' restrooms on both corners of the building, so you can walk quietly and utilize the rooms and then come back. So for now, if you need anything else, let us know. My name is Esther Fuentes. I'm the Business Development Coordinator for Doctors Hospital at Renaissance, the Behavioral Center, and Inpatient Rehab Center. So we are going to get started in just a few minutes. I'm going to go ahead and turn it over to the Alzheimer's Association, and here it is.
Thank you so much, Esther. Wholeheartedly. I do want to say thank you for all of your patience at registration. We had many more people than we had registered, which that is a fantastic problem to have. I want to welcome every single one of you here today. We very much appreciate that you have an interest enough to be willing to spend your entire day here with us to learn as much as we all possibly can about the latest on Alzheimer's disease and everything else. We have an incredible group of speakers, of experts in the field, some local, some from a very long way away, and we are just really thankful to all of you and to all of them for coming to help educate us on a topic that we all need so much more information on. I would like to say wholeheartedly thank you so much to Doctors Hospital at Renaissance for this incredible venue, for the breakfast, for the staff that they have here. We have had by far the most incredible experience. We do a lot of these conferences, and I think we can agree this is by far one of the most beautiful place, first of all, that we have ever been, the most organized, and we just really appreciate all the hospitality of Doctors Hospital and all of their staff. We want to encourage you on the breaks, or if you just need to slip out at some point, to visit the exhibit tables that we will have set up out in the hallway. We want to make sure that you do leave with not only this education, but as many resources as possible. So please make sure to visit and stop by and pick up as much loot as you can. You just never know when you might need some of that information. Also want to thank very much the volunteer committee that helped coordinate and put on this event today. Closer to the end of the day, we will do a special recognition to the committee, so I want to say thanks for all of their hours and time and passion that they put into this. I think logistically that Esther went over restrooms. I'm going to turn it over to Joe, who will explain very specifically. He is our contact person for providing the CEs, and our partner from the Alzheimer's Association in this conference, and a very important one, obviously, because they are helping so much with making sure the CEs are correct. For anyone that came in a little bit later at registration, we will make some copies and make sure that you have everything that you need today for the CEs. And so I will turn it over to Joe Zapata. And I meant to say, I'm Jenny Funk from the Alzheimer's Association, and later we'll have Belinda here, and then Marie is from our office as well. And again, we are overjoyed and thrilled that you all are here with us today, and so I'll turn it over to Joe.
Thank you, Jenny. Thank you. And I share Jenny's sentiment in every word. We're so thankful to be here and to have this wonderful conference to present to you. And we have so much in store to present to you, and very, very informative presentations and speakers. So Jenny covered a lot of things. Let me just get to the meat of the subject as far as paperwork. In your folders, in your purple folders, you have one of these. It is a participant profile. It's a profile that's completely voluntary. You can enter as many or as much information as you want, or none at all. But let me inform you on this. We were able to provide this conference at a very low cost, or even free for some individuals, due to past participants filling out these participant profiles, which afforded us a grant to provide you this conference. So doing so will provide abilities for other individuals to attend future conferences provided by us and the Alzheimer's Association. That's for everyone in the room, doctors, students, presenters, anybody, caregivers. Another very important form is the statement of attendance. If you are seeking some sort of continuing education credit or some sort of certificate, you must fill this out and return this back in at the end of the conference. If you're seeking APA credits, please provide your license number along with this form. If you do not return this form, you will not receive any credit. And following this conference, you will be emailed a evaluation via SurveyMonkey. You fill that survey out, complete the evaluation, and then you will receive your certificates via email. And doing that very quickly. So everybody in this room should be able to get their certificates by within 2 weeks or less. So that's pretty good. I want to again mention the Alzheimer's Association conference evaluation that you'll complete and turn in by today. This is also a very, very important form. It helps the Alzheimer's Association provide information to feature and to better help the next conferences that we have, and to point out what specifics are you looking for and how we can better help you and the community. So without further ado, I'd like to help introduce Belinda. She is a Alzheimer's associate. Yeah, come on up. She's going to help us introduce the first speaker, our keynote. So please, a round of applause for Belinda. Thank you.
Good morning, everybody. Everyone is so quiet. I think we still need our coffee to sink in this morning. Thank you so much for being with us this morning and getting up early with us to learn all about Alzheimer's and have a full day of some really great and wonderful speakers that are going to share their time with us. But it is my privilege to introduce our keynote speaker, Dr. William Thies. He is the former Chief Medical and Scientific Officer of the Alzheimer's Association, where he oversaw the world's largest private nonprofit Alzheimer's disease research grants program. Dr. Thies was instrumental in bringing the Alzheimer's Association International Conference, known as the AAIC, under the umbrella of the Alzheimer's Association activities, and played a key role in launching the peer-reviewed journal Alzheimer's and Dementia, the Journal of Alzheimer's Association, as well as the association's Research Roundtable, which provides a unique forum to senior scientists from the pharmaceutical industry, biotech, imaging, academia, and the National Institute. So please help me in welcoming our keynote speaker, Dr. William Thies.
Well, good morning, and thank you for that terrific introduction. I have to say it was blessedly short. One of my big aggravations with my own office is that we send out about a page and a half worth of crud about what I do and did and all that sort of thing. And then sometimes I come to these meetings and somebody reads the whole page and a half. And I just squirm through the whole thing because I know that even my mother doesn't want to know half of that stuff. So thank you for sitting through it this morning. So I'm going to talk to you a little bit about the current conditions in Alzheimer's disease, particularly medical management, but I'm not going to spend much time on that because most of you know that that's really not the answer. And I'm going to spend a lot of time on what I think is coming in the future. The only thing I warn you about that is that it's a little bit like the stock ad, you know, that comes up and they say this stock is terrific and it's going to make you rich and famous. And then at the end there's a lawyer that comes on and says, you know, this is making future-looking comments and it's no guarantee from past performance. And so I'm going to give you the same disclaimer. These are things that I think are going to happen. We've got some evidence that they're going to happen. We will find better ways to treat Alzheimer's disease. The one thing that is not always clear is how rapidly we find those things. So the world of Alzheimer's disease up until now, up until 2011 really, was largely described by this first slide, and this is something you're all familiar with. You know that Alzheimer's disease is a debilitating disease, so loss of functional independence, behavioral problems, nursing home placement sort of things are common. They're part of the process of the disease. But this graph really is largely aimed at describing the part of Alzheimer's disease that is dementia. And that was originally formulated in 1984 in a formal way in a set of guidelines for what Alzheimer's disease was, and those 84 guidelines were in place until 2011, and they depended on the presence of dementia to identify Alzheimer's disease. Fortunately, we've learned a lot over the impending years, and so we'll see a little bit about how that's beginning to change. So with these 84 guidelines and the definition of Alzheimer's disease, a characteristic dementing disease, people were able to develop some medications. You're probably familiar with most of these. The Tacrin you don't see anymore because it's toxic, and so people don't prescribe it anymore. But the next three, donepezil, rivastigmine, and galantamine, are all medicines that work as anticholinesterase compounds, so they all work the same way. You can't really mix them very well because they're going to have the same kind of toxicity. Memantine works a little differently, works in another system rather than the acetylcholine system, but it works about the same way. And these drugs all have the same characteristic. This slide is actually one of the earliest slides that came from the Aricept studies. And what they show is that if you look at a group of people who've been treated with these drugs and a group of people who haven't, is there's a fairly rapid separation. And we're a little challenged here because I can't point way down there. And you guys probably can't see over here. But there's a fairly rapid separation between the treated and untreated group. And what you can see is this graph lasts 26 weeks. So when that data was first presented, it was a suggestion that we really solved the Alzheimer's problem, that you just give these people this medication. I've already cheated and brought one of my own, but that's okay. You can leave that for people who aren't interested in drinking out of the bottle that I use. So with this data, it looks like we've solved the problem. And the only difficulty is that scientists can't leave well enough alone. And they aren't happy saying, well, we solved the problem, so we don't do anything else. They did longer experiments, and what they found was that with these medications, you see a characteristic that's shown on this slide for the line that says symptomatic benefit. And that is that you get some improvement. You get some improvement in people's state, but it doesn't last very long, and eventually the progress of the disease overcomes the effect of the drug. So you get this characteristic bump in function and then a decline, and you'll notice this decline is actually parallel to the untreated group. And these lines are pretty much parallel. And so the satisfaction with these medications is not very great because a couple of years after you start them, people aren't any better or worse than when you started. And it was pretty clear, the last one of these, I'm going to go backwards. The last one of these drugs that was introduced was 2003 of these symptomatic drugs. And the field largely left looking for more of these kinds of drugs because they didn't see that there was great benefit. going on from there, the field started looking for some drugs that would actually maintain function for people with Alzheimer's disease. These are often referred to as disease-modifying drugs, and they represent most of the work that's being done currently. Now, it turns out that finding disease-modifying drugs is more difficult, and the main reason for that is that if you look at the characteristics of these curves, the symptomatic drugs separate from the control group fairly rapidly, 26 weeks, and it usually separates after 14 weeks or so. But the disease-modifying drugs are actually just slowing the course of the disease, and so the lines separate much more slowly, so current trials have to be as much as 2 years. And so that gives you a much longer, much more expensive sort of trial, and much more difficult to interpret, but we're beginning to see some progress in that direction. So, turns out that when we start looking for disease-modifying drugs, and given the fact that we've learned some more information, the 1984 guidelines about what Alzheimer's disease really was became inadequate. And so in 2011, the Alzheimer's Association and the National Institute of Aging got together and did some new criteria for Alzheimer's disease. And the new criteria are significantly different. Alzheimer's disease is clearly recognized as a progressive disease that had a number of stages, and the 3 categories. It's a continuum. So any time we divide it up into sections, that's kind of artificial, but it helps in thinking about it. And what you can see on this slide is the 2011 guidelines have pointed out that there are 3 stages of Alzheimer's disease. There's the dementia stage that we're all familiar with, and that's pretty much the same as what was identified in 1984. There also are earlier changes in Alzheimer's disease that come before dementia, and they're part of a progressive brain disease that is really a reflection of the loss of brain cells. So these earlier stages include mild cognitive impairment that probably most of you have heard about it, at least. I don't know how frequently that diagnosis is made in McAllen, but it's a condition where people are becoming forgetful, but they're not to the level that they can't maintain their own affairs. So people with mild cognitive impairment routinely are living on their own, they manage things, they find ways to cope, but they're being more and more aggravated by memory lapses. And then a third section, which we know the least about, but it's pretty clear that there is a time in Alzheimer's disease where you have Alzheimer's pathology, you have the characteristic amyloid plaques and tau tangles growing in the brain, but there's no symptoms that we can really pick out. You know, the brain's a wonderful redundant device. You can actually lose big chunks of it and still function pretty normally because it finds other circuits that will do the same work. And so probably in this pre-symptomatic period, that's what's going on. The brain is coping with the insult of the Alzheimer's disease. There's a little bit of a problem with the way we measure people's cognitive function too. There's enough error in there that there may be tests that are very sophisticated that would show some decline in this pre-symptomatic stage, but they wouldn't show up in anything we use now for looking for dementia, because that's a pretty serious aberration in people's cognitive ability. So what do we need in order to really use these criteria? The real difference is that we have to be able to identify pathology in place in the stage of mild cognitive impairment and certainly pre-symptomatic Alzheimer's disease. Until fairly recently, that's mostly been done at autopsy, but you know that free-living people are sort of unwilling to undergo an autopsy. So the fact is that there's been a desire to look for what are called biomarkers for Alzheimer's disease, and it's really a worldwide effort where a number of places are looking for characteristic changes in some body fluid or some imaging marker where you can actually see a change in those markers related to the progression of Alzheimer's disease. And this slide is just looking at the centers that are looking at it. Worldwide ADNI is a program that's managed by the Alzheimer's Association. The main reason we do it is because we would like all of these places that are trying to collect biomarker information to do it in a consistent fashion so that they can actually compare their data. And it's turned out to be very successful in terms of establishing consistency, so you can actually compare data that you get in Australia to what you see in Europe and the United States, and that's becoming increasingly valuable. And what it's really led to is this particular slide. Now, I will say, if you get anything out of this lecture, this slide's really important. And the reason it's important is because it's become a standard in the Alzheimer's world. If you present yourself as an Alzheimer's expert, which I'm doing to you today, I'll admit that, and you don't show this slide, you've put your credentials into question. So everybody who gives an Alzheimer's lecture has to show this slide. It's kind of like having a union card. So what it is really looking at is across the bottom of the slide, you're looking at the progression of Alzheimer's disease from pre-symptomatic on to the demented stages. And when you're looking at the colorful part of the slide, you're looking at a series of biomarker changes that can be measured and can be measured with some consistency. And they're staged across the stages of the disease, with pre-symptomatic showing some changes in what's called amyloid, and we'll talk a little bit about what that is. And then later on in that stage, you see some changes in tau, which is the other characteristic lesion in Alzheimer's disease. And then later on, you'll see some changes in some imaging markers, both of function and structure. But what you can see on this slide is the cognitive performance and functional ADLs really don't change until quite late in the course of the disease. And so this is somewhat concerning. I'd say this is quite a young audience. I talk to lots of lay audiences, and they tend to be more senior. And so when I start talking to them about the fact that all these biomarkers are happening way before you're likely to become demented, I can see the audience squirming in the seat, trying to figure out if they can cure them, their brain accumulating amyloid. You guys don't have to worry about that for a few years, most of you. But the fact is that rather than the anxiety that this may cause, this kind of data gives us the possibility of identifying the early stages of Alzheimer's disease. And what I'm going to show you is actually treat those early stages pretty early on, with the possibility of actually preventing the disease. So the target, again, is the slow disease progression. Certainly there's interest in finding the ultimate target, which would be something that would maintain function. I'm not going to say much about a cure, except that that's on a totally different timeline and probably represents kind of Star Trek technology. So we're a long way from getting to cures. One of the biggest theories about how Alzheimer's happens is that there's an accumulation of a protein, a normal protein called BetaAmyloid. And when you're young, BetaAmyloid pretty much passes through your brain and is cleaned out of the body and doesn't accumulate. As you age, the protein changes subtly so that it gets just a little bit bigger. And when it gets just a little bit bigger, it gets sticky. And when it gets sticky, clumps together. So this amyloid has an interesting structure. It's the blue molecule here, and it sticks through the membrane. Now, one of the things that is true about Alzheimer's disease is we're missing a lot of information. So this whole big molecule is called amyloid precursor protein. We actually have no idea why that was put on Earth. It probably was not given to people to give them Alzheimer's disease. That seems like an unreasonable biological design. So probably that does something, but we really don't know what. And so as we start looking for molecules that may slow down the cleavage of this APP into amyloid, we are going to have some unexpected effects, and we're actually learning about those now. So first thing that happens is the top clips off of this, then the middle part clips out, and the middle part is the amyloid molecule, and that's what accumulates in the plaques. And this slide is showing the two characteristic lesions of Alzheimer's disease. These are amyloid plaques, they're extracellular. These are tau tangles, they're intracellular. And the tau actually fills up the cell body and eventually kills it. The amyloid plaques do the same thing. They'll kill cells as well. It's toxic to cells. And so we are farthest along in finding ways to limit amyloid accumulation. There is a theory, the amyloid hypothesis, that says that if you limit amyloid accumulation, you can moderate the course of Alzheimer's disease. We don't know all the details of that, but that's the theory. Now, it's probably true that most, meaning at least 51% of the scientists that work in Alzheimer's disease, believe that hypothesis to be the case. But I will tell you that there is occasionally some debate about this at varying levels of civility. And so we really won't know the answer to whether the amyloid hypothesis is really true or not until we can actually limit amyloid accumulation in people and see a change in the course of Alzheimer's disease. Now, that's proved to be a fairly elusive task so far, but I'm going to show you some data that reflects on the possibility that this is really real and that we'll be able to use amyloid limitation as a therapeutic direction in the future. So one level of evidence that I'd like to show you is genetic information. And so, you know, the country of Iceland sits up in the middle of the Atlantic Ocean, and there's nothing around it, and the population doesn't change very much. And so some years ago, people identified that as a real opportunity to study a fairly sequestered genetic population. And so there's a big project up there to collect the genetic material from everybody in Iceland. That's been fairly interesting on a number of bases. But just about a year ago now, this letter was published, and it was pointing out that there was a very small number of people in Iceland who didn't get Alzheimer's disease, and they had a very specific mutation, gene mutation. And the gene mutation was interesting in that what it did was that it caused a change in this beta secretase molecule that we're showing here. And with that change, what you saw was no accumulation of amyloid and no presence of Alzheimer's disease. Now, that's really good if you're a person with that gene. Turns out that it's a very rare gene in Iceland, and when you get out of Iceland, it's even more rare. So it's not not a mutation that's of great public health interest, but it does really suggest that inadequate beta secretase function or lower beta secretase function is going to result in the manufacture of less amyloid, less accumulation, less Alzheimer's disease. So that's really encouraging, but until you can actually modify people, you're really not going to get anywhere. So I want to go on to look at some recent data that was presented by Eli Lilly, and this is looking at a drug. It's a monoclonal antibody that actually binds to amyloid, and they did a very long study. It was 1,000 people over 18 months. Costs $400 million, so it's not a trivial event. And what they found was that if they, and I ask you to look mostly here on the, let's see, it's on my right side. It's right side looking over here too. And in this data over here, the blue line are the placebo group, and this is looking at their decline in function. We don't have to dwell on what that decline is. And the red line is the treated group. And what you can see is that these two lines are actually divergent. It suggests that if you go out far enough, they'll continue to diverge. And this suggests that people who are being treated with this medication actually have a slowing of the course of their Alzheimer's disease. Now, this was done in people who had Alzheimer's disease by the old definition. When the trial started, the new definition wasn't even in place. So it's people who were clearly demented, and it was a mixture of people who had mild and moderate disease. What's most interesting about this data is that it looks like the effectiveness of this drug was largely limited to the mild portion of the group. So this suggests that, or fits with the idea that you really need to treat people very early in Alzheimer's disease. This thing is really designed to frustrate me. So this is really going to be most effective if we can see it work in people very early in the disease, and may in fact work much better in people who are not demented, people who are in the earliest stages. Ideally, you'd like to get to a stage where you can identify people who are in the pre-symptomatic phase of Alzheimer's disease, because nobody really wants any part of Alzheimer's disease, and treat them at that stage to prevent Alzheimer's disease going forward. Keeping track of the time. And this is really just additional data showing it not only works on people's cognitive function, but works on their activities of daily living, which tend to moderate much slower. But interestingly enough, I think these lines are much more convincing that the lines are actually diffused or separated. Now, this is one trial, and out of some technicalities, the trial was not adequate to allow the FDA to approve this drug for sale. So there will be another trial of this medication coming up, starting almost any minute now, and I think that's going to be particularly important. So when people want to know when we're likely to have some answers for Alzheimer's disease, one thing that I can say is we're beginning to see data that suggests that we might really have answers in a predictable future in 3 to 5 years. We might actually have something that fits in the medicine cabinet, because when I sit at my desk, I answer my own phone, and one of the things that is characteristic of my job is that I get to sit in the middle of all the science, and that's really exciting because I get to see progress on a daily basis. I also get phone calls where somebody said, gee, my brother was just diagnosed, or my mother was just diagnosed. And what I realize is that there isn't much advice for those people because there is not something that can fit in their medicine cabinet right now. And that's something we drastically need, and we're working as hard as we can to get to it. And we're beginning to see maybe the light at the end of the tunnel for the first drugs that might become disease modifying. They won't be the last drugs, they won't become the best drugs, but once you have targets that are validated and companies actually understand what their drug has to do in order to be more competitive in the marketplace, they're really good at making those better drugs. So I think we will get there in what is a pretty short future at this point. We'll leave that off. One of the things that we ought to talk about is the need to include people in clinical trials. We can't do these trials without having enough people in them. That's a chronic problem. For these Lilly trials that we showed you, it took roughly a year and a half to recruit the population that was going to be tested. And that's a repetitive barrier. So it takes a year and a half that it adds onto that trial. It's going to add another year and a half to the next trial, a year and a half to the next trial. You don't have to go very long before you actually are 10 years behind. So we're trying to move that along. I didn't see whether there was a slide up here for Trial Match. The Trial Match is a free service that's offered by the association to match people with clinical trials in their area. I highly recommend Trial Match because it at least gives people an opportunity to decide whether they want to take action or not. And we don't go quite so far as to assure people that they'll have superpowers, but maybe that's the answer. So I should say just a word about other things that are coming forward. There's another trial that's going on right now with a drug called Ivig that some of you may be familiar with. It's an immune globulin. It's a normal blood product. It's shown some promise in slowing the progression of Alzheimer's disease. Their trial is due to report out virtually any minute now. You know, it's a little hard to predict which day that's going to happen on, because as soon as they know the answer, they have to say something. Otherwise, they get in trouble with the Stock Exchange Commission because they're worried about somebody manipulating stock prices. But the fact is that we're going to know in a couple of days whether that particular compound is useful in treating Alzheimer's disease. That ends up being an important proof of concept. There's some technical problems with Ivig in that the drug comes from pooled blood that you collect from the community, and there's a fraction of that contains Ivig. So it's relatively expensive and has a limited amount of basic material that you can collect the drug from. So it's been used for a long time to treat certain kind of immune diseases. So there's been a very small market, and so the cost of the drug is prohibitive. In the trial that's going on, the cost of the drug that they're using would translate to about $80,000 a year for one patient. So you can see we're not going to use Ivig in everybody. We can't afford it. There might be some opportunities to make artificial Ivig or to find other ways to collect more blood and make more of it. Those are all possibilities. It certainly brings up some interesting ethical problems, because the main use of it outside of Alzheimer's disease is for little kids who become dependent on it because they've got immune deficiencies and they'll die if they don't get it. And so the idea of all of the Ivig being sopped up by an Alzheimer's population and it being taken away from little kids brings up the idea of rationing or something like that. Right now there are some people that are being treated off-label, and you don't know who they are because that's not something that becomes public. I have to say I get a fair number of phone calls from people that say, gee, I heard about this IVIG, I want to try it on Uncle Charlie, and so we have a conversation about the risks of using drugs like that, and that's fairly academic. Usually that conversation ends when we get to the price, and I point out that it's pretty expensive, and most people just say, well, thank you, that's fine. And every once in a while I get a phone call from somebody who says, well, that's really no problem, we can afford that. When I get those phone calls, I then change to another pitch, and I talk to them about whether they'd like to adopt an aging scientist who could enjoy their support. So we are going to see some disease-modifying drugs, and I think we're going to see them sooner rather than later, and they're going to make a terrific effect on the field. The introduction of biomarkers like amyloid imaging are going to become critical in identifying patients that we treat early. So let me tell you what I think the future represents for Alzheimer's disease, and this is really just a little cartoon that shows the progression of the disease, and right now all of the work is being done on the far right of the slide for the treatment of Alzheimer's disease. About 5 million people, and you're trying to treat cognition and slow progression of the disease. But what I would like to present to you is actually that research is going to move very quickly to the left on this slide for a number of reasons. One is that patients don't want any part of Alzheimer's disease. They really don't even want mild cognitive impairment. So they're going to start demanding treatments that show promise earlier and earlier in the disease process. The other thing that's going to make an effect is that one of the problems that I think we have is that physicians, many of them, don't like to treat Alzheimer's disease. They don't like to even diagnose it because it's a fatal diagnosis with not much of a medical intervention at this point. And that really doesn't give much gratification to the doc. The doc has been trained to identify a specific disease and to give a definitive intervention that prevents that disease from going on to a more serious condition. And so I think lots of docs stay away from Alzheimer's disease, and that's too bad because it's a growing problem. If we had a medication that was giving medical benefit, I think we would greatly improve that. And so two of the driving forces are, moving to the left would be greater patient satisfaction, greater physician satisfaction. The other reason that it's going to move to the left is that if you look here at the middle where it talks about numbers, that's the number of people. So we have 5 million people. This is an old slide, and I never changed this number. I'm embarrassed by it. So we've been at 5.4 million for the Alzheimer's disease with the association, but those of you who study facts and figures religiously, right, the document we put out with all the numbers, will notice that this year, because of the variation that you get in measurement, we're actually back down to 5 million. So I'm now correct again, and I'm not going to have to change my slide. Terrific. So there's some good data that says there really are 5 million people with Alzheimer's disease. The data on mild cognitive impairment is not as good, but some data that says there's 2 to 3 times as much mild cognitive impairment as there is dementia. And then finally, in the pre-symptomatic stage, we have almost no data, but that number, I have great confidence in that number, the 20 to 60 million number. And the reason I have great confidence in it is that I just made it up at my desk one day. So the source is absolutely unimpeachable. But the fact is that we know there's going to be more people with pre-symptomatic disease than those that don't have pre-symptom, that are further along in the disease. And so the third driving force is that actually you can sell more pills to 60 million people than you can 5 million people, and that message is not lost on the companies that sell pills. And so we're gonna harness actually the two great forces in American society. It is the demand of the consumer and the profit motive of the companies in order to move very quickly to the left, where we'll try and identify people very early in the course of the disease, and that will result in the prevention of developing dementia. Now, at this point, I think it's reasonable for you as an audience to be fairly skeptical of this presentation. Now, there are some elements. I mean, I am an Alzheimer's expert, and you can tell that because I come from more than 50 miles away, and I have a PowerPoint presentation. So that's the definition of an expert. I'm there. I'm good. But I got a burden here. You know, Yankees have been coming to Texas and trying to sell you stuff for a long time, and so I can see where you might have some concern about that. So I'm going to try and give you a case study here. So this slide is actually showing the history of the epidemiology of cardiovascular disease over the last 100 years. It's too bad that these are all CDC numbers, and they didn't really collect numbers much before 1900. And it's too bad that they didn't, because if you went back earlier and earlier, what you'd see is that the numbers looked a lot like Alzheimer's disease, our projections going up over the next 30 or 40 years. In fact, the original description of a myocardial infarction is fascinating. It was done in the late 1700s, and the original description, pathology, was spot on. You know, they were talking about a clot in the coronary artery and muscle damage downstream, and that muscle damage was severe enough you ended up with a fatal condition. So that all looks pretty much like we see today in a pathology report. But the clinical description was a little bizarre. The clinical description in 1780 was that these myocardial infarctions happened very rarely. You almost never saw them. You'd have to work years before you saw two of them. When they happened, they only happened in really old people, like people over 50. That plays better in an older audience. We've got a couple of people here over 50. Me personally, I take exception to that, right? So what happened between 1780 and 1950, when we got to the peak of these curves, as you can see on this slide? Lots of people got over 50, right? And when that happened, you had a virtual epidemic of cardiovascular disease. So what started happening in the middle of the last century that really changed these curves? And what really happened was we began to understand the underlying pathology of vascular disease primarily. We got a little bump from getting a little better at handling emergency cases. But mostly we understood underlying pathology. We treated that underlying pathology by controlling people's blood pressure, controlling their serum lipids. And what happened was that began to prevent cardiovascular disease. So what I'm proposing to you is going to happen in Alzheimer's disease over the next few years. I don't want to be too specific because it'll just be wrong. You can guarantee that. But over the next 2 years, we are going to begin to see medications appearing that actually treat the underlying causes of Alzheimer's disease. And in doing that, we have the possibility of turning the curve over in the same way that the cardiovascular world has done. And that will be a terrific advance and something we need to get to, because we simply can't take care of all the people that are projected to have Alzheimer's disease in the next 40 to 50 years. That's that. So I think this is a good place for me to stop. I think there's time for questions. Somebody will bring out a big hook when I need to stop. Yes, sir.
I'm a counselor, and one of the things I see when I deal with family, the patient and the doctor, they somehow associate event that marks a decline on functioning, the cognitive mental functioning of the patient. Usually they say, my father was doing okay, he went to a hospital, he underwent minor surgery, and they associate that with the decline. What would you advise telling me these families?
Well,
I hope I don't put you in the spot. That's
no, it's fine. So for everybody who can't really hear that, the question was, lots of families will assign the onset of dementia to some event. Dad went into the hospital, he never came out the same. Can't trust those damn docs. I mean, they kill everybody. Everybody who goes into those hospitals just never comes out again. What I can tell you is it's human nature. And there's lots of things that happen in our life and we can't explain them, but human nature is to find an explanation, right? And so in the same way that people invented some explanation of what lightning was 1,000 years ago, families will try and do that. And there are some characteristic things that do trigger that kind of thing. Hospitalization that's characterized with extended general anesthesia, the death of a spouse, serious head injury like an auto accident, something like that. And in most cases that has nothing to do with the progression of the disease, except that the disease has been going on and this is a marker, and maybe there's something that happens that just tips the person over the edge. I mean, the best example of that is the death of the spouse. You know, Dad was doing great, he was terrific, and Mom died, and he just hadn't been the same ever since. Well, the fact was that Mom and Dad were functioning as a pair, and every time Dad forgot something, Mom was poking at him saying, I mean, I have a wife at home, and that's what wives are for. And it works the other way, that's what husbands are for. But the fact is that what happens is that you take away one of those supports, and then all of a sudden everybody recognizes the loss of function that's been going on. And I think you may want to spend some time explaining that to people, but don't have great hopes that they're going to incorporate that and understand it. I mean, the best example we had of this was in the big hurricane in New Orleans. There were all sorts of people living in the community that were having cognitive problems, but their whole community was supporting them in an informal fashion. The hurricane came, all that support was removed. Suddenly, there were all these demented people that had to be dealt with because their support was removed. So I think that's the general formula. How about somebody way over there at the end? Somebody must have a question because I can't even see him over there. Yes?
Well, I've got a couple of questions, but one of them is...
Should we wait for the...
Okay. Anyway, the environment has to play some kind of function in this because there's all of a sudden there's so many people with Alzheimer's when before there wasn't. So I go back to your Iceland thing and I go, well, that's a bunch of crap. I did say that in my mind because it's happening everywhere. Yes, you find a few little people that for some reason they didn't get it, but you give something a name and now everybody's got Alzheimer's. Before, even, because I can go back, like you said, years after Daddy died, which I don't think had anything to do with this, but I go back now and remember Mom trying to do a scratch ticket. And then she just scratch. And she goes, Cynthia, you know what? Something's wrong with my mind because look at this. And I go, oh, Mama, you're 80 years old. You know, we have to forget once in a while. My point in this case is that how do you actually, in your studies, really stop and say, when did it really start? How do you find that? Because at 86 now, she's functioning fine, but her mind is a little, emotional, up and down, up and down.
Well, there's a number of really complicated questions in there, so I'm not sure I can deal with all of them, but there are some of them I can. First, certainly the recognition of Alzheimer's disease as a disease state has increased over the last 30 years, and that supplies part of the recognition of more people with Alzheimer's disease. But the number of people with the disease, let's ignore whether they're diagnosed or not. The number of people with the disease is going up, and it's going up because people are getting older. There is no evidence that there's any systematic change in the environment except those things that let people get older. And we could do away with those things, but that's not a future most people want, right? The therapeutic option to increase Alzheimer's disease is not letting people get older, and most of us aren't going to sign up for that. So the fact is that there is no evidence that it has anything to do with the sort of characteristic environmental factors that we think about as air pollution and water pollution and that sort of thing. So, and it is clearly a disease. It can be seen as pathology, and in fact, at 85, about half the people will be demented. Now that's awful, certainly, but the other half of people are cognitively normal, which suggests that this is a disease process that can be dealt with and treated. In terms of when does the disease start, a lot of that's definitional because this is a continuum, and depending on what you define, if you define the first time the two amyloid molecules clump together as the beginning, that's going to be a little hard to pick out because that's a very small event in a big brain. But you certainly could set a cutoff. We do that for everything else. If you're concerned that that isn't precise enough, you know, you get numbers for what a normal blood pressure is, right? But the data is perfectly clear. The lower your blood pressure is, the better off you are until you become unconscious, right? And we still have a cutoff. That's a purely artificial, man-made. There's a committee in Washington that gets together and decides what's an appropriate blood pressure. They've been doing it for 30 years, and that's where the number comes from. So we probably won't be much different than that. But over here.
I have two questions for you. My first question is there any research that suggests that there's a prevention for Alzheimer's?
Okay. Well, in fact, all of these medications are aimed at looking for that. These are medications that the disease-modifying medications will most logically fit in a preventative mode, where you'll give it to people very early on to try to prevent the later stages of the disease. In terms of a non-medical prevention, there's a lot of data that suggests that certain things are good for you. None of that data is going to really lead to a prevention in Alzheimer's disease. But if you're interested in leading a lifestyle that minimizes your chances of Alzheimer's disease, I'll give you my rules, and there's data, variable data behind it. Number one is get more physical activity. Okay, seems strange that this is a mental problem, but if you're physically active, you get less Alzheimer's disease. We actually have the best data for that. There even are a couple of small clinical trials that demonstrate that if you take groups that are at risk and give one group exercise and the other not, the exercise group will develop dementia at a slower rate. So number one would be more physical activity. Number two is is keeping track of your medical state, particularly your medical numbers. You should know your blood pressure, your blood lipids, and your blood sugar. And if you need treatments for those, you ought to get them. It's probably the second level of evidence for that. The third level of evidence would be for diet, and the advice there is not very specific. It's eat more vegetables and less fat. If somebody comes and tells you, you can avoid Alzheimer's disease if you just eat all grapefruit, don't walk away from that person, run, because that sort of advice never works, and there isn't any data that really suggests that's useful. But some dietary evidence, and that would be a third level of evidence, and probably the lowest level of evidence, but what gets lots of attention is that if you keep your brain active, you'll get less Alzheimer's disease. I think that evidence is the most confusing, least coherent, and there's absolutely no evidence for what I frequently get is, well, I used to do crosswords, but I see this Sudoku stuff. Is that going to be better than doing crosswords? There is no evidence that one kind of mental activity is better than another. And with all of these activity changes and even dietary changes, the one piece of advice I'd give you is do them in a way that you like it, because if you don't like it, you won't incorporate it into your life, and it'll just be a momentary aberration, like all the people in the world, including myself, who are in the middle of losing 10 pounds, and we've been in the middle of that for the last 50 years, right?
My second question
Oh,
is...
yes,
it's okay.
I lost track.
What are your thoughts on prescribing antipsychotic medications to people with Alzheimer's disease?
Well, I think it needs to be done very carefully. Actually, if you go to the Alzheimer's Association website, you can find a fact sheet about the use of antipsychotic drugs in people who are demented. Probably there's more use than is justified. What that fact sheet says is that several things. Number one, before you even use the drugs, you should have a definitive target for what you want to achieve. So it's not just, we need to calm down Mr. Jones, but rather, this is the outcome we're seeking. And if you're an advocate for a patient, you want to have the conversation with your doc and say specifically, what's really the target of giving them this medication. Second, it should be limited in time frame. It shouldn't be forever, and lower doses are the best. So I think it's something you do carefully. There are people who will call for the elimination of these kinds of drugs in people who are demented. I think that takes away a valuable tool from the physician. So I don't agree with that, but I think you want to do it carefully.
Thank you.
Nobody's come out with the hook yet. Ah, there's one down there. If you don't ask enough questions, I'll just stay up here.
I feel silly asking this, but I feel compelled as well. If you're your own caretaker, how do you look at yourself and determine that it's time to ask the doctor for Aricept or Namenda? What do you look for in yourself?
Well, I think that's virtually impossible. One of the things that happens as you develop the disease is that people typically begin to lose insight into their own condition, and there's a natural tendency to deny the existence of health problems anyway. It's just a low indigestion. It's really nothing serious. There's an elephant will get off my chest in a minute now. And so that's part of human nature, but part of the change in the brain in Alzheimer's disease results in a loss of appreciation the significance of the loss of function that the individual has. So I think the only thing you can do in that setting is find a physician that you really trust, have them monitor your condition on a regular basis, and he's going to have to make the decision about when you start those drugs, recognizing the limitation of those drugs. They're far from miracle drugs. They are only going to be valuable for a short period of time. They don't work in everybody. I think one of the biggest parts of dissatisfaction with the current medications is that if you look at the clinical trial data, about 1/3 of the patients who get those medications have a fairly robust effect. About 1/3 get a very small effect, and about 1/3 don't get any effect at all. And so if you're in either of those last two groups, your satisfaction with the medication is going to be fairly limited. But I would be really careful talking to my doctor about that. And yes?
In your studies, is there any indication of what we're eating now, like all the chemicals, processed foods, nitrates and all that, would that take any kind of effect on us as far as Alzheimer's is concerned?
There really isn't any data that anyone would consider convincing. And the fact is that you can show correlations between lots of things. And if you've got one thing going up in society and something else is going up at the same time, that's going to look like there's some correlation between the two. But there's no need for that, right? So what's happened about the same time we've seen increases in our appreciation of number of people with Alzheimer's disease. Well, the stock market's gone up, so maybe that's caused it. It's hard to find an association. One of my favorites is we are now being bombarded with microwaves at a level that we've never had before. So if I really was going to have a conspiracy, I don't like cell phones. I hate them because they bother me. People come and find me when I don't want them to. That would be my favorite conspiracy. There's no evidence, but you know, conspiracies are way more fun than any evidence-based idea anyway. So I think there's really no evidence that past what we already said about diet. More vegetables, less fat, that's good for a lot of things, and there's lots of really strong evidence for that.
Dr. Thies, can you tell us what NAPA is and what does it stand for?
Yes, NAPA is the National Alzheimer's Plan Act. So it is was presented in Congress as an act and was voted on. All you guys that watched Sesame Street know about Bill and how Bill becomes a law. And if you didn't see that on Sesame Street, we even used it a lot. We stole from it when we were promoting NAPA. But that is now a law. And so what the law says is that the United States will have a national plan for Alzheimer's disease. It is now in its second year. And the plan is actually out. You can find it on our website. You can find it on the congressional website as well. And it talks about a lot of things, all the way from how we fund and organize research to how we fund and organize delivering care and education to caregivers and all of those things. If you look at the plan, it has a lot of stuff in it that would really be good. If we got to the end of that plan, we would have a much better world for people with Alzheimer's disease. It is a key goal of the association to see that that plan occurs. It isn't going to happen in 20 minutes. It's a 10-year plan, so it's going to have to be evaluated every year for progress. In a time period where you all know that the government's not really excited about spending more money with trillions of dollars in deficit, it is going to be difficult to actually demand that this plan be followed. Now, we have some advantages.
The NAPA Act itself was a unanimously passed piece of legislation. So that means that Republicans or Democrats or Independents or whatever, everybody voted for it. So everybody could see the face value of it. As we go back to Congress and say, gee, you guys voted for this and it's not happening because we're not doing this part or this part or this part, that's going to be an interesting part of the activities of the Alzheimer's Association for the next many years, really. And if you guys are interested in knowing more about that, come to our website. We have a public policy forum coming up, and you know, I'm a doofus scientist, so I don't even remember the date. What's the date, Jenny? There you go. So April 21, 22, and 23. There's a forum in Washington where you can learn more about the process. You can go meet your legislators and advocate for it. We are going to need everybody's cooperation with this if we are to achieve the endpoints of NAPA, which would actually be a wonderful new day for all of the people with Alzheimer's disease and all the people who work with it.
Thank you, sir. Thank you very much for the presentation.